Hello, everyone, and welcome to today's webinar, Simplify Your Gastrointestinal Testing with Real-Time PCR, Impact on Patients and Laboratory. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by BD. To learn more, visit bd.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. And with that, I'd like to now welcome our speakers. Joining us today is Dr. Margie Morgan, Professor of Pathology and Laboratory Medicine, Scientific Director, Clinical Microbiology at Cedars-Sinai Medical Center. Dr. Heba Mostafa, Associate Professor of Pathology, Director of the Molecular Virology Laboratory at Johns Hopkins Medicine. And also joining us today is Dr. Dylan Pillai, Professor and Department Head, Departments of Pathology and Laboratory Medicine and Microbiology, Immunology, and Infectious Diseases, the University of Calgary. Also joining us for discussion during our Q&A session today is Kayla Kirby, Global Medical Science Liaison at BD. For a complete biography on our speakers, please click on the Presenter tab. Dr. Morgan, Dr. Mostafa, and Dr. Pillai, thank you for joining us. You may now begin your presentation.
Thank you so very much. So I'm going to start with how do we even establish the diagnosis of, and so we can start our GI testing? Well, first off, we need to know what really is diarrhea. So IDSA has defined this as the passage of 3 or more loose or liquid stools per day. Which pathogens should be considered in a patient with diarrhea? Well, of course, the physician needs to take a detailed clinical history and risk factors necessary to select possible pathogens. And of course, IDSI guidelines has provided information to help with this selection. This is all wonderful, but I don't know how it is in your particular setting, but not all clinicians may have viewed these guidelines or be all that well informed about our available diagnostic tests. So I was going to spend a minute talking about the burden of education that laboratories do carry and how we've developed testing algorithms to guide proper test utilization within our laboratory. Appropriate test utilization can assist with a focused diagnosis and is thought to be far more cost efficient for a laboratory and less expensive for the patient. Of course, there's very fine IDSI guidelines that have been created. They go through the clinical symptoms and patient exposure history or risk factors that should guide a diagnosis of acute gastroenteritis. Molecular assays are now recommended for most relevant bacterial, parasitic, or viral pathogens. Diagnostic testing is thought should be more selective and limited to settings in which the tests are more likely to provide clinical useful results. So this leads to key concerns concerning very large syndromic panels and the clinical relevance of all the organisms detected. Also, the impact on healthcare costs. This is the way IDSI guidelines has kind of outlined the exposure or condition associated with pathogen causing diarrhea. So you can see that it can fall into separate panels that can be used for testing. But all of this is easier said than done. So how can we best educate clinicians and nursing personnel to follow these wonderful guidelines and testing algorithms for specimen collection and test ordering? Of course, every health facility is different. In the number of clinicians, for example, I have 2,600 clinicians on staff, most of which are not part of the faculty at Cedars. Also, some might be full-time, some might be private practice clinicians. You might have residents in training that can train at numerous different institutions and get different protocols confused. The same goes with nursing staff that work at numerous facilities and confuse collection practices. So it really does make doing just simple collection and ordering for stools kind of complex. What we did to help us was we've created some job aids and service bulletins that have, believe it or not, been somewhat successful. We made educational tip sheets for our nursing personnel in-house with collection guidelines for specimen submission. We also made laboratory service bulletins for our outreach caregivers. This has been effective and preferred by nursing and physician office managers instead of only providing online computer information. This can be posted in the work areas and provide an ongoing resource for the personnel. But of course, we have computer online information as well. I'm sure all of you have done the same in creating these very lovely websites with laboratory test and collection information. This is, of course, required by regulatory agencies, but we also want to make it available in our our electronic medical record for our nurses and physicians. We've, of course, included available tests, explanation of our tests, the proper specimen submission, and rejection criteria. But I don't know how it works at your medical center, but it has surprised me over time how many people do not even know that this beautiful website exists. And so that kind of puts some problems in our way because they may not be looking at all the best ways to do things. So the first thing is we were determined to lower rejected specimens. Of course, we request unformed or liquid stool. And initially, we used a 4-vial collection set like shown in the picture. We recently just moved to a 3-vial collection. And you could say, why do you do so much collection in so many containers? Well, when we tried to just have them look at our website and then submit just the proper container for the test that they were ordering, it just didn't work out very well, and they often submitted the incorrect vial. So that's why we went to the mandate of sending in the 3 vials for all tests. So no matter what they order, we would have the stool in the proper conditions to be able to do the test. We could do molecular, we could do susceptibility testing if needed, we could do parasite exam, or even we'd have fresh stool for tests like fecal calprotectin. So this has worked best for us. Also, we needed to improve the ordering. So we created what were called soft stops in our electronic medical record. Our clinical decision support programming in our EMR can create an informational soft stop. This has helped us relay information that possibly they're not picking up from reading our computer laboratory guide. One of the examples of a soft stop is if a provider enters an order for C. difficile PCR testing. A non-interrupting order will pop up with the comment, C. difficile assay should not be ordered on a patient who received laxatives within the previous 36 hours. Now, obviously, they can just look at this and say, forget it, blow through it, and not pay any attention to it. But you know, over time, we have found this to be effective. They do take a moment to pause and think, and sometimes it has stopped us from getting stools on patients that have had laxatives. So this approach has been effective for us. There's also other CDS interventions that you can do that could possibly be helpful in your ordering of the correct test as well. Our first step into the molecular world of stool testing was with C. difficile. The PCR was, of course, introduced in the literature as a rapid and sensitive method to detect C. difficile in stool specimens around 2011. And around this time, a little bit later, BD introduced the BD-Max C. diff assay. We implemented the BD-Max assay in 2012 after previously using an EI method for C. diff toxin A and B detection. Well, needless to say, our C. diff rates tripled after we started using PCR because it was such a much more sensitive method. When rates became reportable to the California state in 2016, our rates were well above most other facilities that were still using enzyme immunoassay methods. And at this time, we were hearing rumblings of a two-step testing algorithm that was circulating that could help discriminate colonization from true infection. And we were listening because we needed to do something about this escalated, tripled C. diff rate. So we developed an effective two-step testing algorithm for C. difficile. The first thing we did, however, was we had to go back and, of course, educate once again for proper specimen to be tested for C. diff. We stressed that you wanted to make sure it was a diarrheal stool, and we would reject any hard stools. We want it to be at least the patient has diarrhea. We don't want any laxatives, and we will test only children beginning at 2 years of age. Now the IDSA guidelines have been lowered to 1 year of age. As I said, no form stools were tested. We had a very rigid rejection criteria. We didn't test the young children, and we did not perform repeat testing within 7 days during the same period of diarrhea. Once we had the proper specimen, then we instituted what we thought was an optimal two-step C. diff algorithm. Our first step was doing the BD Max C. diff panel, which was a molecular PCR to detect the C. diff TCD-B gene. The second step is if this test were positive, we would reflex to a stool enzyme immunoassay to detect active toxin A and B. To further explain how all of this worked, we did our BD Max C. diff panel reflex testing. If the test was negative on the panel, we would report as negative for the TCD-B gene with an explanation of our test results, and we would determine that the patient would be neither colonized or infected with C. diff. If it was positive on this panel, we would then reflex and perform an EIA for C. diff toxin A and B. On the left branch, you can see if the PCR is positive and the toxin was determined to be negative, the patient was most likely colonized. The physician, however, made the decision if treatment, of course, is indicated. On the right-hand side is the PCR positive, and the toxin was also positive with testing. This patient was considered to be most likely diseased, and treatment was usually required. And this is the type of patient in the result that we reported to the NHSN network as being positive for C. difficile. As you can see from the top line what our rates were when we did PCR by itself, and below what the PCR and positive EIA results were. So the PCR positive EIA negative was far greater with our two-step testing implementation, the PCR alone, than with the PCR plus EIA. And so that's why we found that the C. diff rates with using the two-step algorithm was very effective and adequately and precisely reported who we really thought was ill with C. difficile. And this has worked very well for us for many years. So we have had success with the two-step reflex algorithm. We're able to detect patients with clinically significant disease needing antimicrobial therapy and isolation precautions. Our rates of C. difficile disease when we had both tests positive are reported to our regulatory agencies. We detect patients most likely colonized with C. diff for implementation of appropriate isolation precautions to prevent nosocomial transmission. We have had no known nosocomial transmission events since we started the reflex algorithm protocol in 2016. The success with C. diff PCR testing using the BD Max has provided the motivation for us to explore other molecular enteric stool pathogen testing. So in the fourth quarter of 2014, we moved away from performing stool cultures. Now, I can go on and on about the complexity of the stool culture, and I'm sure you're aware of it just as well as I am, but there's so many media types that are needed for doing a good stool culture: plates and tubes, various incubation jars, Campi packs, different incubation temperatures, identification methods, methods to screen for Shiga toxin. And with all these wonderful things in place, it can still take us greater than 50 hours sometimes to work out our stool culture results. There's numerous manual workflow motions and decision steps that are arrived at an identification of an organism in a stool culture, besides all the time that it takes to order and inventory all of these supplies, perform QC and such. There was even a paper that was written on this. Dr. Mortensen and his group greatly showed how complicated a stool culture can be and how the BD Max enteric bacterial panels can improve the laboratory workflow compared to doing a stool culture. They found in their study that the BD Max bacterial pathogen panels can have an 82% reduction in decision steps and a major reduction of manual workflow motions compared to the performance of a stool culture. So we also found this to be true. It provided major improvements in efficiency, and also our techs really liked it much better than doing all of the decision and manipulations involved with a stool culture. This is, of course, the way you set up a bacterial enteric bacterial panel. Compared to that slide before, it's pretty simple. You basically just inoculate your specimen into a tube and place it into the instrument with all the necessary components, close the lid, and in 3 hours you have a result. And so all of your samples come in one box, all the supplies are there, and so it makes it very, very simple compared to all the manipulations and products that you need for a stool culture. The molecular stool testing, you could argue, is more expensive than a regular stool culture, but really we have found it not to be so. Of course, cost do vary for supplies and labor across our country with regional differences. Our labor costs are very expensive in California, so we have found that the BD Max stool testing is no more expensive, or at least comparable to conventional culture. You can see on the right-hand side the bacterial panels that are available. You have an option to order the enteric bacterial panel alone or with the extended portion. We have found that our physicians usually order 75% of the time just the enteric bacterial panel. We have non-formed or formed stool submitted to us in Carey-Blair. We prefer it to be in Carey-Blair because in our region we are asked to do susceptibility testing on Shigella on occasion. We've had great improvements in turnaround time. Our laboratory workflow and efficiency compared to culture methods have really been much better, and the CLS, as I said, have been very happy with it. And it's increased our sensitivity, particularly for Campylobacter and Shiga toxin detection. Some additional thoughts. Of course, you're switching from doing a stool culture into molecular testing. So you have to be very aware of strict molecular sterility practices. They need to be enforced to prevent contamination during the stool processing. I also highly suggest performing your testing in a BSL-2 biosafety cabinet. We are able to send an aliquot from the Carey-Blair container to our public health department for follow-up testing. But when you start doing molecular testing, you should talk to the public health department about what type of specimen they would like you to submit. Did the physicians just immediately accept everything and have no concerns? Of course not. We had to have some discussions with the physicians about the change in testing, and once we explained things and they understood our reports, things really went very, very well. But your report should be very informative. It will prevent phone calls. We did have some initial discussions with people about the difference between Shiga toxin versus Shigella. We also, on occasion, will have trying to subculture organisms find that they will not be alive, And that may most likely is because, of course, when you're doing molecular testing, you can detect both dead and alive organisms. Their infection could have been weeks prior, and therefore we may not have live organism available to subculture. So that needs to be explained as well sometimes. So why choose the BD MAX system for enteric bacterial testing? Well, we had familiarity and staff positivity using the C. diff testing, so it really wasn't a hard convincing for us to change over at all. We liked the idea of having focused individual testing panels in keeping with the IDSA clinical testing guidelines. We test for the most relevant enteric infections consistent with patient history and risk factors. And through educating our physicians, we have been able to maintain the most relevant panel testing. It's a cost-effective molecular approach for the laboratory and the patient, more so than a large, comprehensive, multiplex target panel that can face reimbursement challenges. The literature has been positive. We can do batch testing of 24 stool samples and with results in 3 hours. This testing volume falls within our testing needs. It's less than 2 minutes hands-on time for each stool specimen, and it has automated testing with interfaced resulting that can certainly lower different kinds of mistakes that can be made in entering results. Have the enteric bacterial panels been diagnostically impactful? Yes, they have. You can see here that we've had a 4-year-old child rapidly diagnosed with hemolytic uremic syndrome. We had a 70-year-old gentleman with Guillain-Barré syndrome where we found that 2 weeks prior he had had Campylobacter. A 30-year-old male with unrelenting diarrhea returning from overseas with Vibrio cholera. And we've had innumerable cases of Salmonella, Shigella, and Campi, both in and out patients that have been diagnosed using these panels. So it's rapid molecular detection that provides very rapid information for our clinicians. So finally, we found very good effects with the C. diff 2 test stepping algorithm, excellent diagnostic and infection control information, and we've had very successful conversion of enteric pathogen testing to using the BD MAX enteric pathogen panels. So with that, I thank you, and there will be time for questions after the next 2 presentations. Thank you very much.
Hi everyone. Thank you so much for this invitation, and I'm gonna switch gears here to Margie's talk. And thank you so much, Margie, for sharing. Those educational tip sheets are very inspiring. So today I will actually talk to you about our experience here at Johns Hopkins with the gastroenteritis viral panel and its implementation. So very quickly, my disclosure slide. And Margie did define diarrhea, and I would like to just quickly stress on the burden of diarrheal diseases in general, being leading a cause of death, especially in children younger than 5 years old. There are yearly billions of cases and thousands of deaths. And those can happen in kind of endemic or outbreak situations, and even in the US, where we originally think about diarrhea as like low or middle income kind of disease. Actually, in those even in those highly socioeconomic places, there are other risk factors that increase the diarrhea cases and the burden, including admissions, increased numbers of immunocompromised individuals, certain exposures like travel and animal exposure. So diarrhea, even in the US, is a burden with, again, millions of outpatient visits, admissions, and death. And when it comes to the leading causes of diarrhea, viruses actually come on the top of the list along with Salmonella. Noroviruses will be the non-bacterial kind of leading cause of gastroenteritis. And rotaviruses, even though we now have a vaccine, we still see cases globally with a lot of admissions and death. So really like a big problem of diarrhea. And when it comes to viruses, as I mentioned, norovirus is a leading cause along with rotaviruses, particularly in the children. And when we think about what the other viruses are, the common viruses that are associated with viral gastroenteritis, we usually think about noroviruses, rotaviruses, astroviruses, adenoviruses, and saboviruses. Those are the common ones, even though there are some others, but still the clinical relevance of the other ones, they are still not very clear, including, for example, HE virus or some of the coronaviruses. So those are so far the established viruses that are associated with gastroenteritis. So when we look into those five viruses here or viral groups, we actually can see that they belong to four different families that can be structurally different. There are different genetic and antigenic types for each. For those that infect humans and cause diarrhea, for example, for rotaviruses, we can see that there are different antigenic groups. Group A can be the most common and most commonly associated with cases of rotaviruses diarrhea. We can see different groups within this group A, different types, 41G and 57P. So a lot of variations in these viruses that are associated with acute gastroenteritis. And if you also look at the transmission and epidemiology of those viruses, you can actually see that they tend to overlap. So the route of transmission is fecal oral route, which makes sense, even though there are some other questionable routes, including, for example, respiratory route for a few of them. The target population also overlap. So children is the group that is usually most associated with viral gastroenteritis. However, additional age groups can be impacted, for example, with noroviruses outbreaks. And the seasonality also, there is an overlap being sporadic year around, and outbreaks can also happen for most of them. So quite difficult to differentiate those viruses based on seasonality or target population and shared route of transmission. If we also look into their clinical presentations and features, we also see overlap. So you can see that they can be presenting similarly with the non-bloody diarrhea, pain in the abdomen or cramping, fever, nausea, and vomiting. Some of those viruses will be associated sometimes with some extraintestinal involvement or chronic infections. But again, clinically, it's quite difficult to differentiate. So then taking this together with this overlap in the clinical presentation, in the seasonality, in the target population, and the diversity in the antigenic types, groups, and so on, it becomes then important to have a tool in the lab for diagnosis. And when you look into the commercially available molecular assays to diagnose these viruses individually, there aren't actually many molecular options. There are some antigen testing options that were available, primarily actually widely used for rotavirus. But when you look into the molecular methods, you can see a few options that were FDA cleared. Expert norovirus maybe is a famous one because we actually did use this one here at Hopkins, along with RADA. Those were to the best of my knowledge, the only two that were FDA cleared that can test for norovirus. But then, other than that, those viruses can actually or are within FDA cleared panels. And only 3 panels incorporated the 5 viruses: BioFire, BDMax, and the QIAGEN. So these panels then, if when I did think about testing for viral gastroenteritis here at Hopkins, and this was before we implemented the panel, so that was before September 2023. Our way of testing for those viruses included the norovirus expert assay. As you all might know, that this is an easy, quick test. Setting the test can be very quick. Our rotavirus testing was a sent out antigen test. So as you can imagine, this can take 2 days to return the results. And adenovirus testing, we used to do this from stool and rectal swabs using a laboratory developed test that was quite manual. So we had to do an extraction step up front and then set a manual PCR. And our turnaround time for this was between 24 to 48 hours. And we did not offer any testing for either sapoviruses or astroviruses before September 2023. And I personally did not even receive that many requests to send out for these viruses, or at least actually until recently, I did not receive any requests. So I wanted to actually, and I was thinking about bringing the panel for testing, but I wanted to start by looking and seeing what our testing looks like for the viruses that we already either test for in-house or send out. So those included, again, adenoviruses, rotaviruses, and the noroviruses. And I primarily wanted to understand who orders the test. So I did pull the data between December 2022 and March 2023. And I focused this on just looking and seeing if the same locations or the same practices order these viruses. And actually, it was interestingly, they actually did were the same. So the data showed that we test for noroviruses as twice as rota or adenoviruses, and the main practices that ask or order these testing include they are all inpatients and they are primarily transplant or pediatric practices. So that was actually good to know because if we think about consolidating testing, we now can expect that the same locations actually will be interested in the test. Around the same time, I actually did start to receive a few orders for astrovirus, and this is just the one example case of a transplant patient immunocompromised that came to us with a diagnosis of astrovirus prior to this admission at Johns Hopkins. But then he did still have severe diarrhea and actually almost perforated colon. And they did still have that questionable graft versus host disease. So this was one of a few requests that I had for astrovirus that emphasized even more that for our population of patients being primarily cancer or transplant immunocompromised, and them ordering the 3 viruses or the 3 groups of viruses that we have to offer testing for, now it becomes important to also offer the additional viral targets that can impact this population. So I did also look into the data and what was published there about those other viruses that we don't even have data on how prevalent they are in our population of patients. So this was a paper published by a group from Spain looking into their BDMax viral panel data. And their data actually showed that the prevalence of viruses actually came on the top, with norovirus being the high positivity rate among all tested targets. Sapovirus was almost equivalent in positivity to CAMPI, and all other viruses, Rota, Astro, and Adeno, were circulating in high percentages. So altogether, actually, was a very strong justification that implementing the viral panel testing at Johns Hopkins was actually the right thing to do. So our time frames here, we actually did started testing with BD-Max bacterial and parasite in 2016, and it did take us a few years to implement the viral panel here. Now, after the implementation, I wanted to look and see how or what the data looks like and how providers started to use the panel and what is the positivity rates, and did we actually start diagnosing cases? So what was the clinical utility? So I did pull the data right after we implemented the panel between September 2023 to till January 2024. And you can see here that the orders for bacterial and parasite panels were higher than the viral panel during this month, even though the viral panel utilization started to slightly increase towards the end of 2023 and the beginning of 2024. Then when I did look into the diagnosis that we started to make and how prevalent those viruses are, you can see on the right side the graph which is showing the percent positivity, and on the left side this is just the number of the positive tests. So you can see that norovirus comes in the lead for the positivity rates from our population of patients, and we did actually start to diagnose sapovirus cases, astrovirus cases. We also see rotavirus and adenovirus, and cumulatively the positivity rate for viral targets can actually are higher than the positivity rates for the bacterial targets in our population. I was also interested to see what is the algorithm that providers are using to order those tests. So for this, I had to pull a lot of data and look into if providers order viral panel alone, or is it ordered as a part of the bacterial and viral panels. So this, I limited the data pool for a shorter period because of the high number of orders and the analysis needed. And in this time frame, I noticed that the majority of the orders actually come as a joined bacterial and viral orders. However, about 40% of the orders come as a viral standalone test. And you can see that the bacterial and the viral orders together, the majority of them were ordered in the same time, at the same time. But less numbers were ordered either within 2 days or later on. But interestingly, you can see that the positivity rates for viral targets in the three scenarios were actually very similar, and they were higher than the positivity for the bacterial targets when the viral and the bacterial orders were placed together. It was actually encouraging to see that some providers can make a clinical suspicion of viral testing, and they do choose to order the viral standalone test. And it will be actually very interesting to follow up on this analysis a few months from now, when everybody actually starts to use the viral panel more, because it's so far actually is considered quite a recent introduction to the lab. When I did a look into the diagnoses that we started to make, particularly for the non-norovirus infections, I did look into some clinical cases, and we had a spectrum of patients that we diagnosed with adeno, astro, rota, and sapo, a wide range of age. All those patients were legit diarrhea cases, so orders are actually placed properly. We did have a patient who was initially treated with ertapenem and then was diagnosed with adenovirus, and then they did switch the treatment to symptomatic treatment after this diagnosis. We interestingly had a few cases diagnosed with sapoviruses, where when I was reading the notes, the result was not acknowledged or the comments indicated that this was quite new for providers. So they are still kind of navigating the clinical utility of this diagnosis. So again, it will be interesting to repeat this analysis and see how this will look like a few months from now. So to wrap up this part of my talk, within the institution here, taking into consideration that the population of patients are primarily transplant inpatients, pediatrics, the positivity rates of the viral targets is actually higher than bacterial and parasite targets. And that the viral orders were primarily placed by the same practices. It was very, very significant for us here to bring the testing consolidated in a panel for those major acute gastroenteritis viruses. This consolidated our testing. It reduced our turnaround time. We started to make new diagnoses for the viruses that we did not test for before. We specifically targeted the gastroenteritis adenovirus types. Our lab developed test previously was not specific for the types 40 and 41. So we are now making more specific diagnoses for this. And I am expecting that this will actually have even more positive clinical impact and significant utility, and will also provide us with data on the epidemiology and circulation of those viruses in our institution here. So with this, I'm gonna pass it to Dylan, and thank you so much, and a quick thank you here for the entire lab and for BD for assisting with the verification of the panel.
So good afternoon, and thank you very much. The last talk today will be on culture-independent stool testing, the Calgary experience with parasites. And my name is Dr. Dylan Pillai. I'm a medical microbiologist and professor at the University of Calgary in the Department of Pathology and Laboratory Medicine. I just want to start by acknowledging that the University of Calgary is on the traditional territories of the peoples of Treaty 7, which includes the Blackfoot Confederacy, Siksika, Piikani, Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. So a disclaimer, the views and opinions expressed in this presentation are those of myself and do not necessarily reflect those of Becton Dickinson. So learning objectives for the talk today. The first is to describe new technologies in the diagnosis of gastrointestinal infection and critically evaluate the impact of molecular diagnostics in infectious diarrhea. Finally, to correlate culture-independent diagnostic testing of gastrointestinal pathogens with clinical disease. So to start off, the epidemiology of diarrhea is that approximately 3 to 7% for adults and higher for children is roughly the prevalence in North America. So 3 to 7% for adults and approximately 8% for children. Again, in the United States, the estimates are close to 50 million cases of foodborne diarrheal disease annually, and over 10,000 deaths per year due to diarrhea, with the majority in the elderly. C. difficile, or Clostridioides difficile, is the most common cause of death, followed by norovirus, salmonella, and listeria. And viral gastroenteritis is a major contributor globally due to rotavirus and norovirus, and these are more prevalent in developed countries. In terms of transmission, Shigella and norovirus have the highest transmissibility with infectious doses as low as 10 to 100 organisms. Giardia, Cryptosporidium, both parasites, and Salmonella in infants occur with an infectious dose of approximately 100 to 500 organisms. And a lower rate of transmission is seen with E. coli and Campylobacter with an infectious dose of more than 500 organisms. Infection with parasites is typically due to fecal oral transmission, due to contaminated food, or other exposures. So this an example of that is E. litica and the MSM population. Continuing with our introduction, so parasitic diarrhea typically lasts for weeks with a protracted course. Microscopic methods often lack sensitivity, and this results in the need for repeat testing, and often 2 to 3 stool specimens are required on separate days. Enzyme-linked immunosorbent assay or ELISA methods have also lacked analytical sensitivity in terms of detecting at low-level infections. And most common causes in non-endemic setting are Cryptosporidium parvum, and Cryptosporidium hominis, as well as Giardia intestinalis. There's some debate about the pathogenicity of Blastocystis hominis and Dientamoeba fragilis. So I'd like to now dive into, having completed that introduction into the context, the implementation of the BD-MAX enteric parasite panel in Calgary. So historically, detection of ovine parasites has occurred using stool microscopy. And there's some advantages to this. First, the reagents are relatively cheap, and most parasites are identifiable based on specific morphology that's seen in microscopy. And for this, of course, technologist training is required in order to identify those specific features. Some of the disadvantages, of course, is indeed that trained personnel is required. It can be time-consuming to look through these slides and labor-intensive, and sample preparation is also critical here. One could also argue that the sensitivity of stool microscopy is relatively low. Again, as mentioned before, this prompts often repeated testing and requirement for stool specimens. And morphology is sometimes challenging based on identifying the species. So with this in mind, we look to undertake an evaluation of molecular testing, and the instrument in question here is the BD-MAX instrument. Here you can see a photo of the instrument on the right with the technologist there on the left, to give you some perspective in terms of the the space that's required for the equipment and the fact that it can be a benchtop device. So the first step in our validation was to review the literature, and we were fortunate enough to have a publication that had evaluated this technology previously. And here we see the results of a prospective evaluation for 3 different organisms. On the left, Giardia, Cryptosporidium, and Entamoeba histolytica. And so you can see the true positive, false positive, true negative, and false negative rates as compared to different methods, including a DFA method, a PCR method, and the composite. And if you look over at the far right, you can see the total number of samples involved, as well as the sensitivity specificity numbers, which were encouraging in order for us to proceed with our evaluation. Sticking to the same publication, there were also results on retrospective specimens. So these are specimens tested previously and stored and archived. And again, the 3 organisms on the left, Giardia, Cryptosporidium, and Entamoeba histolytica. And again, you can see that the sensitivity specificity numbers on the far right are relatively encouraging in order for us to consider implementing this test. Finally, this is the comparison of the BD-MAX enteric parasite assay compared to a composite algorithm for unpreserved and formalin-fixed samples. And this is an important point, because in your laboratory, you may be using unpreserved stools or you may be using formalin-fixed stools. And so it'll be important to know if the performance of the molecular test is appropriate for that particular specimen type. So for Giardia, you can see, again, on the far right, that the sensitivity and specificity numbers are fairly comparable between formalin-fixed and unpreserved. Similarly for Cryptosporidium parvum, and we do see some data as well for Entamoeba histolytica. Again, in our particular setting, we were in a scenario where we did have access to unpreserved stools, and so that was our initial thought, was to proceed with validation in unpreserved stools. So here's our typical turnaround times or testing times in our setting, and this is probably very similar where you are. On the top, we see stool culture. This is routine bacterial stool culture. Typically, identification occurs in 48 to 72 hours, and then, if necessary, susceptibility testing can be done thereafter. For us, over and parasite testing, again, depending on the time during the week, can take anywhere from 3 to 5 days. C. difficile testing, in our setting, we use a two-step algorithm using a GDH screen followed by a PCR-based toxin detection algorithm, can be typically 24 hours to 36 hours. We also historically used a Giardia cryptosporidium enzyme immunoassay, which was relatively quick, under 24 hours, as well as a rotavirus EIA. So here were some of the retrospective data in our laboratory in terms of annual testing on the stool parasite bench. And in red, I've marked the organisms that are the most prevalent in our setting. You can see Cryptosporidium, Dientamoeba fragilis, Entamoeba histolytica, /dispar, and Giardia lamblia or intestinalis are the 4 commonest stool parasites that we identify. Importantly, Entamoeba histolytica /dispar is a slash call there because using a morphology, we're unable to actually distinguish the pathogen histolytica from the non-pathogen dispar. And so this is an important distinction, as the molecular assays are specific for the pathogen Entamoeba histolytica. So you can see that our positivity rate is approximately 7.4%. And indeed, our 4 species in question here account for about 67% of our positives overall by ovarian parasites. So these are the predominant organisms. And a screen for these 4 species would be, in theory, valuable. And so we looked at what panels are commercially available that would screen for these most common positives. And of course, one question that remains is, how do you deal with other positives that are not detected by the multiplex panel? Of note also, I will mention that Dientamoeba fragilis had this questionable clinical significance, and so that leaves us with the 3 other organisms, Cryptosporidium, Giardia, and Entamoeba. So we undertook a phase 1 retrospective analysis, similar to the publication, where we relied on archived specimens that we'd kept in the freezer. And here you can see some of our data. When we compared the BD-Max EPP assay to the EIA or ovarian parasite testing. So this is a composite, essentially, gold standard, if you will, and comparison. And you can see that the numbers are fairly concordant for Giardia and Entamoeba, with perhaps some false negatives identified for Cryptosporidium. And in a prospective analysis, here we, in real time, use the BD-Max assay compared to our gold standard. In this case, we used a molecular consensus. So we had other commercial manufacturers of stool parasite testing panels, and we considered a molecular consensus where 2 out of the 3 panels were positive as the gold standard. So 3 simultaneous molecular assays tested prospectively. And again, you can see that when we compared molecular versus molecular, that Entamoeba looked quite good. Giardia, again, 96% sensitivity and 97% specificity. And perhaps Cryptosporidium, again, perhaps lacking a little bit of sensitivity, but specificity looks good in the prospective analysis compared to the molecular assays. So one of the things we noted is that with real-time PCR methodologies, that the amplification curves sometimes need to be looked at closely, because they may not give you that classical exponential or sigmoidal curve. And so we discussed this with the technologists and realized that sometimes medical scientific consultation would be required. And as we did our validation, we found that certain steps were critical. For example, in red, if the liquid is not mixed with the sterile stick before sampling, that can sometimes cause problems. So we were quite particular on that point. And then, of course, the SBT, or the sample tube, should be tea-stained in color, and that's a good sign that we've got the right inoculum and the right setup for the extraction. We then informed key stakeholders in our setting. We have a centralized laboratory which include both acute care and community physicians. And so we did undertake some stakeholder engagement with our family doctors, emerge doctors, our ID consultants, gastrointestinal physicians, and our public health department, who were interested to know how microscopy, traditional O&P compared to molecular assays, as their definitions of infection would have to be modified accordingly. And we made a decision to move forward with the 3 pathogens in question, but we also thought it would be useful to screen for risk factors in order to determine if patients would just get the molecular screen, or the molecular screen and the full ova and parasite testing for the other potential pathogens as well. So we adjusted the test requisition. You can see here the stool parasite screen does not require patient history, and you would get the molecular screen up at the top. But if you did want the full ova and parasite, including the molecular screen, we did require further information to justify that, such as travel, recent immigration, immunosuppression, or evidence of blood in the stool, which we felt were key risk factors for further investigation. And a case history form was also implemented to triage for appropriateness, where physicians would have to indicate the clinical history here on the left, the exposure history and travel as needed. And this was important epidemiological data, of course. In the same way, stool, ova, and parasite testing has a flowchart was also disseminated in order to assist clinicians in terms of their thinking and thought process. If you follow along the left, there are no risk factors, and parasite testing is not suggested. But of course, if there are risk factors such as traveling or residing in a developing country, then you would get the full ova and microscopy on the right-hand side. And this algorithm was deemed useful for our stakeholders and clinicians to test appropriately. So the impacts were interesting because by implementing the screen and the case history form, we found that there were more molecular screens done, as most times clinicians were interested in the 3 pathogens in question, and there were no significant risk factors. And the number of ova and parasites concomitantly went down over time as a result of this screening. If we look at the positivity rates, all pathogens in question, Cryptosporidium, Entamoeba, and Giardia, all had an increased detection as compared to our previous methodology, which was an EIA. And indeed, if you looked at the overall percent change, including the screen and the O&P, you can see that, again, we had this increase in positivity rate. So in spite of the decreased number of ova and parasite tests and increase in molecular screening, we actually were able to detect more. And in fact, Entamoeba histolytica increases seen are specific for the pathogen. So we're not detecting Entamoeba dispar as we did previously. So in summary, culture-independent molecular testing can improve patient care and laboratory service by improving detection of enteric pathogens. Implementation of multiplex molecular panels requires a full analysis in terms of the clinical value, the cost benefit, certainly in our setting here in Canada, and the laboratory impact. And syndromic testing is ideally implemented by triaging for risk factors, as we showed here, using a screen for risk factors, and then encouraging appropriateness in testing. So I'd like to thank the medical, scientific, and technical staff at the Diagnostic and Scientific Center, where I work here in Calgary, Alberta, and I thank you very much for your attention. I'm going to turn it over now to the moderator to field any questions for any of the 3 speakers. Thank you again.
All right. Well, thank you, Dr. Morgan, Dr. Mostafa, and Dr. Pillai for your informative presentations. As we will now start the live Q&A portion of the webinar, I'd like to welcome Kayla to join us here as well. And to our audience, if you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. Kayla, I'll pass it over to you.
Thanks, Kaylee. All right, let's get started. So the first question will be for Dr. Morgan. Is the C. diff testing algorithm at your institution the same for both inpatients and outpatients?
Well, that's a very good question. Thank you for asking that. We do not have a huge reference laboratory. We're not like a Quest or something like that. We get maybe 300 or 400 specimens a day, so it's a controllable population. Most of them are Cedars physicians, which we do have ability to educate. We do use the same criteria. However, we do have, on occasion, issues with receiving firm formed stools, and we call it a non-conforming event, and we do have our client services make phone calls to tell them that the stool is formed. Sometimes they do get in arguments, I have to admit, with our client services people, and on rare occasion we've had to test perhaps a stool that we don't deem ideal, but we try to use the same criteria for in and outpatient.
Okay, thank you. This next question will be for Dr. Pillai. Parasites are often in cyst form. Can molecular testing access DNA from organisms in this form?
Great question, and yeah, that's one of the challenges with molecular testing of parasites is you need to crack open that shell, so to speak, and try and get to the DNA. But fortunately, the extraction methods utilized in the BD Max platform perform very well, and so we were able to, in fact, achieve greater sensitivity using the molecular methodology. So, in summary, this is something that needs to be looked at when you're deciding on the platform of choice, and an appropriate validation studies need to be done. But the short answer is yes.
Thank you. Yes, we have that pre-warming step ahead of the instrument. This next question will be for Dr. Mostafa. Can molecular testing be used as a treatment of cure for viral infections?
This is a very good question, and it's actually one of the we think as and advise not to do, kind of. Viral panel testing in the stool has the same limitation that can apply to viral testing, for example, in a respiratory panel, where you can have that prolonged shedding for a long time. So testing for cure is not really a good idea, because it might add confusion to the interpretation of the results. I don't think this is a good approach, and it's not also advised to do that per recommendations.
Thank you. I do have another question for you, Dr. Mostafa. Was there a significant difference in treatment practices when viral testing identified a pathogen versus prior to implementation of the viral testing in your lab?
In our lab, this analysis actually, I did not do that extensive analysis yet. I just looked into the a subset of patients, and within this subset of patients, there was just a one straightforward answer to this question, where I saw an initial empiric treatment with ertapenem that was discontinued when we diagnosed a virus. But to have a better view and a more statistical kind of a meaningful analysis, I still need to look into a larger cohort. And to do that, I actually just started to collaborate with clinicians to do this analysis, and I'm writing an IRB already. Thank you.
Thank you. This next question will be for Dr. Morgan again. So ordering providers have busy days and tend to, see as many patients as they can every day. What do you think could be helpful for them as sort of a quick guide as they attempt to narrow down the most appropriate enteric panel to choose for their patients, in the case that their lab does use smaller panels like the BD Max enteric panels, rather than a larger multiplex panel?
Well, that's a very good question. I'm not sure I'm going to provide a very good answer, because I think every clinician practices in a very different way. We have had personal communications on different process improvement committees and talked to many different groups of physicians, including our GI folks, our infectious disease folks and also hospitalists. And we've tried to discuss how to go about ordering these separate panels. But I cannot tell you how they have organized it in their own practice to do so. But we do see a differential in the ordering of different types of panels, including viral and parasitic. So all I can tell you is I'm sure that each physician does have a way of going about it, but I apologize, I cannot tell you about how they might be doing that.
That's okay. Thank you for your answer. Dr. Mostafa or Dr. Pillai, do you have any other perspectives that you would like to add to that question?
Go ahead.
Okay, I will move on to another question for Dr. Pillai. How frequently is parasite testing done in your lab? Is it done daily or weekly?
Yeah, so I think that's another good question. It really depends on the volumes that are happening, in your setting. For us, it's a daily test, and that really improved those turnaround times that I mentioned. Previously, stool over and parasite microscopy occurred, on the weekdays, but not the weekends. And so it depended when the samples came in, your turnaround times could be affected. In this case, we were able to actually implement a daily test. And so the turnaround times did improve, and our clinician stakeholders were very, pleased with that. So in our setting, it's a daily test. And I think Dr. Morgan mentioned the throughput of, 24 specimens there per run, and you can, have multiple runs during the day if needed.
Mm-hmm. Thank you. And this question will go to Dr. Morgan. Do your clinicians ask for a separate call out of E. coli 0157? And if so, how are you handling that request?
They do not. I've not had many requests, if any, for that, but all of our Shiga toxins are sent to our local Los Angeles Public Health Department, and they send back the report of the specific type of Shiga toxin that we detected. It might be a tad bit delayed, maybe up to 5 to 7 days, but they will eventually get a report of what toxin it is.
Okay. Well, thank you. I think that is all of the questions that we have. So that concludes our session today. Dr. Morgan, Dr. Mostafa, or Dr. Pillai, do you have any final comments for our audience?
Thank you so much
for listening.
Yeah, thank you.
Thank you very much.
Thank you.
Thank you. I'll pass it over back to our moderator to conclude.
Great, thank you, Kayla. And thank you again to Dr. Morgan, Dr. Mostafa, and Dr. Pillai for your time today and your important research. We would also like to thank LabRoots and our sponsor, BD, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by our speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.